All right, we're back with chapter 35, part 2. Okay, so if you would go ahead and turn, if you're not already there, page 670, 671 is where we're at in our book, and I will go ahead and share my screen with you again. Go ahead and bring up the slide that we left off with. And again, just some great information if you want to just sit and look at this. Um, you know, to just kind of get a good picture of just what it allows you to see, and some combination of some of the pictures I used. Okay, the second part that I really want you to pay attention to as well. And let me come back for one, let's see, is it there? I want to come back one more time before we get away from this on page 670, your patient teaching on varicose veins. Again, important to read through those, really understand those, and remember again that one of our concerns when our patients do have venous thrombosis is that it will then go into a pulmonary embolus. We don't want it to travel to the lungs, so we also want to catch that right away if a patient starts having any symptoms of that. So we want to make sure and educate them on what they need to notify us of. Okay. Okay, the next one, table 35-1, covers a little bit, but this is definitely one of those sections that's definitely a combination of the book and lecture. So I want to just go over this with you, and that's talking about ulcers. Now, chart number 35-1 has a lot of different things comparing arterial to venous disease in the legs. I really want you to read over that and look at the difference. It tells you, for example, if you're talking about ulcers, peripheral artery disease and venous disease. In the artery, where do we see the location, the margins, the drain, and color, and then going over and looking at venous disease and how does it look different, okay? So when you're talking about arterial stasis ulcers, the locations we tend to see these are on the tips of the toes, the foot, the lateral malleolus. Indicators of arterial insufficiency is when we see these, that's an indicator of arterial insufficiency. And this is serious, probably a progressive disorder that could lead to further skin breakdown. Okay, with venous stasis ulcers, characteristically they're painless. They're near the ankle, they're warm, they're ruddy in color. And so, you want to be able to differentiate between where, one is and the other. And is it venous? Is it arterial? Okay, so make sure you pay attention to that. Okay, on page 672, when we are talking about venous thrombosis, we have another patient teaching box. Please make sure and study that as well as going through the ones right below that. You've got your inadequate peripheral tissue perfusion and your impaired pulmonary oxygenation. Okay, those are key and very important. The possibility of a pulmonary embolus developing during the treatment of venous thrombosis is a very real thing. Okay, when an embolus lodges in the lung, the affected blood vessels again can no longer exchange gases. Okay, pressure builds up in the vessels behind that embolus. Symptoms of pulmonary embolism depend on the amount of tissue again that's being affected. Small emboli may produce no symptoms or very little. Your larger emboli again can cause shortness of breath, chest pain, tachycardia, fever, cough, anxiety, and even a change in mental status. So I'm going to ask you, if you're not getting good at gas exchange because of an embolus in your lungs, why would somebody's mental status change? Think about that for a second. What do you think's happening? What happens in the lungs? The blood that's deoxygenated goes to the lungs for what to happen? For it to get reoxygenated. But if we get a blockage in there, right, and we're not able to have gas exchange take place, what are we lacking then? We're lacking oxygen. What happens to the brain when we lack oxygen? Yes, those cells can die. But all of a sudden we start getting we start seeing a change in mental status because we're not getting the oxygen. You don't believe me? Take a patient who needs oxygen, who's desatting horribly. Now, I'm just being facetious. I don't mean really do this, but if you were to take that oxygen off that patient, or if that patient was confused and took it off themselves, you could notice their mental status change rather quickly, can't you? Get it back on, get them to take some deep breaths, and all of a sudden they're coherent again. I've watched it 100 times, 1,000 times, you know. But what are we monitoring for? We're watching with venous thrombosis, chest pain and shortness of breath. What are the symptoms that we might see, you know, if our patient was to exhibit a PE, chest pain, shortness of breath? We would want to know that right away, right? All right, the next thing we talk about is called intermittent claudication. And I am messaging Melanie back because she's trying to help with something for your class and I already fixed it. And forgot to text her. All right. All right, so the next thing we talk about intermittent claudication. Now, this is a funky one because it's mentioned several times in this chapter, which I'll mention, but it really covers it in detail on page 602, which is in chapter 33 on cardiac that we just finished. But we don't really get into it as much in cardiac. It's one of the ones that they moved it out of vascular into cardiac, but then they bring it back in and test it during this chapter. So I want you to pay attention to this section, okay? So intermittent claudication is chronic pain that's associated with decreased perfusion that has been aggravated by exercise and it's alleviated by rest. Well, when we're exercising, what do we need more of? Oxygen, right? And when we rest, we don't need as much oxygen, right? So intermittent claudication can affect any major muscle group that's distal to or beyond the point of an arterial occlusion. Okay? The pain is described as a feeling of tightness, burning, fatigue, aching, or cramping. Exercise, so here it is. Exercise causes that muscle group to become ischemic because blood flow is inadequate to supply the nutrients and oxygen to remove waste. So this results in the development of pain. So when exercise is stopped, the metabolic demands of the muscle tissue decreases, it doesn't need as much oxygen, wastes are removed from the tissues, and the pain goes away. Okay? Intermittent, meaning it's intermittent, so when it happens, it's not constant. Okay? And so, again, the symptoms of claudication associated with peripheral arterial disease usually manifest in the muscle groups below the area that's being affected. So let me show you a picture. Okay, so this is a picture I found that I thought you would find interesting. And this is talking about how if you have an area that's obstructed, for example, up high in the aortic or iliac arteries, everything below that area is where you're going to notice it. So let's say it's affected in the popliteal artery, which is right behind the knee. Below that, the calf and the foot would be what's affected. Okay, so you can see how as you get lower and lower, everything below it, the higher you get, the more areas that it would affect. Okay, so again, symptoms of claudication associated with peripheral arterial disease usually manifest in the muscle groups below that hemodynamically significant lesion. When it means hemodynamically significant, your hemodynamics are your blood flow and how they're working, right? So if it's occluded, whether that's an area of plaque and it's spasmed around it, whatever it is that's blocking, causing that occlusion, everything below it, it's going to affect that blood flow not getting to where it needs to go because of that specific place. Okay, so just something to think about. Okay, yeah. Chronic, I'm just going to pull out some key points here. Chronic venous insufficiency is the culmination of, well, yeah, there we go, sorry about that. Chronic venous insufficiency is the culmination of long-standing pressure that stretches the veins and it damages the valves. And remember we said those valves can't be repaired, right? So if they get stretched out and they become insufficient and don't work right, that's when we have an issue, right? So elevated venous pressure causes the swelling, the edema, primarily around the ankles. We see red blood cells that will then seep into the tissues, combined with metabolic waste to impart a brownish color. We've seen that on lots of patients, haven't we? Kind of the brownish color across the calves and lower legs. Because those RBCs seep into the tissues, combined with those wastes to make that color. This is called Stacey's dermatitis around the ankles. Ulcers may form because the pressure exerted by the edema also, or as a result of trauma, of course. Signs and symptoms of chronic venous insufficiency include edema around the lower legs, pain, brownish skin discoloration, as we just talked about, the Stacey's dermatitis. You should know that definition, what it all looks like, right? And Stacey's ulcerations. The physical examination provides evidence of chronic venous insufficiency, just like we talked about what it would look like. So you have to look at this and say, what would my patient look like that came in with chronic venous insufficiency? When I assess them, what are they going to look like? You should be able to look at this and it's telling you how their legs are going to look and why, right? The medical management of Stacey's ulcerations is constantly changing, but as your book says, compression, which promotes venous return, remains the key to healing existing ulcers as well as preventing new ones. And then among the many options are elastic compression stockings and pneumatic compression devices. When the patient has chronic venous insufficiency, you want to inspect the lower extremities for Ruber and Stacey's dermatitis, palpate skin temperature, evaluate for edema, and determine the presence of pain in those affected extremities. Okay? So again, know what the signs and symptoms are, know why you're seeing that discoloration, and so on. Okay, study that section out well, okay? And then we talk about lymphangitis. Lymphangitis is an acute inflammation of the lymphatic channels. Inflammation is the result of an infectious process, usually caused by Streptococcus. So here's a perfect picture. You can see along his arm that channel becomes inflamed where the lymph fluid goes. So there's an infection going on. So we watch the red line follow the track of infection. Okay, those are kind of scary when you see those. Signs and symptoms. The primary characteristic of lymphangitis is enlargement of the lymph nodes along that channel. Each node can be usually palpated along the channel. The patient will usually complain of tenderness when you assess those nodes. A red streak from the infected wound ends up going along the extremity along the path of those lymphatics as each node drains into the lymphatic system and the cardiovascular system. These nodes are located in the groin, the axilla, and the cervical regions. The symptoms of a generalized infection, what do you think? Fever, right? Elevated temperature and chills are usually present. The infectious material can localize also into an abscess with necrotic superlative discharge from the area as well. The classic signs and symptoms are usually how we diagnose this. The doctor diagnoses it, supported by a wound culture results, and usually that's adequate enough, as your book states, to confirm lymphangitis. Lymphangography uses a contrast medium for radiologic visualization of the lymphatic system, and it also will show evidence to support that it is lymphangitis. Okay, usually it's treated with antimicrobials. If an abscess develops, the area is usually incised, and drained. I've actually seen that happen a few times. It actually looked almost exactly like this, except for that it was darker red. Other supportive measures would be, a lot of times the doctor will order rest, elevation of the limb, warm, wet dressings, elastic support hose can be a few of them. Again, as nurses, we're making sure to inspect the skin, looking for any open wounds, signs of inflammation, redness, warmth, edema, and so on. Okay, and then of course, they're probably really uncomfortable. So we want to help to relieve that pain. Give them the prescribed analgesics and their antimicrobials. Okay, get those on board. And then your book talks about a lot of other just options that you can have, like soaking and so on. Remember again, that infectious material can localize into an abscess, as I said before. Okay, so we want to pay real close attention to that. Any changes, any swelling when we're checking that area. Okay, so that's the really big one that I want you to pay attention to there. And then, as we have finished the chapter, the last thing that you're going to be finishing with is your clinical connection assignment, and I will post that on your page for you out of this chapter. Okay? All right, guys. Take care.